Thank you. I feel like everything needs to start with music. Good afternoon. Thank you for braving the cold and coming all the way to the North Pole here to this room on the other side of the world. We are here to talk about Medicaid innovation in the Southern Belt. And we hope to really talk about not just kind of the gaps within technology, workforce, and policy, but kind of how those braid together specifically in the Southern Belt. And we are here in the South, if you haven't noticed. We are in Tennessee. And it's freezing, which is not what you typically, or at least what I typically equate with being in the South. So God bless our weather here and our global warming. So I'll just start by just like doing a bit of framing, but I'll first introduce myself. My name is Adamika Meadows Arthur. I am the CEO and Executive Director of Health Tech for Medicaid. We are a nonprofit organization that really bridges kind of technology and innovation in the Medicaid population. And a lot of people would ask kind of why Medicaid? I often get that question. And that is because it really serves about 79 million individuals today. 1 in 5 Americans are on Medicaid. And 7 years ago, when we started Health Tech for Medicaid, it was really kind of unheard of that people would be investing and thinking of technological solutions in the Medicaid ecosystem. Now you're hearing Medicaid buzzed around. And quite often I would say that is a dream that was dreamed up of ours many years ago. And with hard work and with incredible entrepreneurs like those on the stage, investors, policy folks, we are here. So we really say that we're on a mission to radically change the pace of innovation in Medicaid. And I think just in our time in the world, it's going to be more important than ever, really, to advocate for this population. Last week we got a new HHS secretary, I think he's still learning what Medicaid really is. And so I think that that's going to be really important for us to advocate for such a large portion of the population, and certainly a large portion of the population who lives within the South. So why the South, and where did this come from? So first, I'll just step back and say a little bit about my background. I'm an epidemiologist by training, so like a true public health person. Because of Medicaid, I did a lot of work around the Medicaid expansion work 20 years ago in the state of California. So the first 1115 waiver to expand Medicaid in California, which then became essentially one of the first states to expand Medicaid across the country. And then that was taken through the ACA to expand Medicaid across the country. A few years ago, we expanded our 40th state, which was actually in the South, in North Carolina. And in that year, which was 2 years ago, we expanded both in South Dakota and in North Carolina, which is our 39th and 40th state. In most of the Southern Belt, while we do have states that have expanded, like Louisiana and North Carolina, we also have states that have not expanded. And the good majority of states that have not expanded are concentrated in the South. And so one of the reasons why we have a Southern strategy is due to a couple of things. One, the investment on the innovation lifecycle and ecosystem. The amount of investors that are investing in the Southern Belt are much lower. The amount of innovators coming from the South, the amount of incubators, accelerators, et cetera, are much lower. And I know Colby will talk a little bit about being a part of one in Tulsa and how they're up and coming, but there really isn't a lot of penetration in the Southern Belt. And there's also a tremendous amount of growth in the South. So shockingly, we have a lot of migration into the South. A lot of our older adults are moving south. It's cheaper. A lot of people migrated north many migrations ago or years ago, or they grew up in the South and they like to move back home after they've retired. But it's also coming at a time where we've shuttered our health environment. Many rural hospitals are closing and our urban hospitals are closing. So while we have more people moving south, we potentially have less health resources than we've ever had before. So that really became a a call for us about a year ago where we really wanted to start facing some systemic barriers, specifically in the South. In addition to that, when you're looking at disease burden across the United States, we see a tremendous amount of disease burden in the South. We also see e-migration and immigration patterns in the South as well. So a great deal of people who come into the United States come into the South. So there's a great amount of very unique and interesting language patterns that are in the South. So really a rich set of unique characteristics that had us want to really invest, innovate, and really start thinking about a Southern strategy. Anyone here, just because we have a large group of people in the audience here, anyone here live in the South? Just a few people in the back? Okay. Do you think that this is the right place for us to be putting our focus and our energy in the South? Yep. Okay, good. Well, I'm excited later to hear reasons why, and we'll make sure we have kind of an interactive set of conditions. Clearly, the state of the South, this is just a typical KFF map that is looking kind of at the South, and I think I've talked a lot, so maybe I will skip ahead a little bit. We can go back to reasons why we're looking specifically in the South. But I've talked a lot about coverage gap. I've talked a lot about aging and elderly populations. That also brings up another piece that we're seeing in the South, which really has to do with the increase of Medis, or dual eligible individuals, people that have both Medicare and Medicaid. But they also, the growing sense of people of what we call the forgotten middle. They're individuals who are the most at risk within the next 5 years of being dually eligible. And so they're on the cusp. They really are like a half a paycheck away from really not having the services that they need. And then I think we've also looked at a lot of workforce shortages that are deeply important, and we'll talk a lot about ways in which we can address the workforce shortage gap. And I think we'll also talk a little about novel and unique ways, whether it be through public health interventions or otherwise. How do we get to some of these rural populations? What are some tech-enabled resources that allow us to use or enable technology to allow people to remain and stay healthy and also stay engaged? All right, that gets us to, I'll get to demographics probably later. That gets us to the South, to our today's panel. And what I'd love to do is have each panelist just kind of introduce yourself. And as you introduce yourself and kind of what you do, maybe also just say why this particular topic or why this demographic in the South was of most interest to you as we kind of introduce ourselves moving ahead. And I'll start with you.
Thank you, Adamika. And I don't think the size of the group in here is a reflection of the issue. This is very important. There's a snowstorm coming, but thank you everybody for being here. And thank you HT4M for holding this. This is such an important conversation. I'm Kirsten Baker, CEO of Genie. We are a virtual interpreting platform that is created to eliminate language barriers. And we've just been talking about kind of the situation in the South. And, there is, as Adamika was saying, there's so much kind of systemic kind of disease in this widespread in the South, heart disease, diabetes. It's also, the diseases are also kind of more prevalent in Medicaid recipients, and 60% of Medicaid recipients show up language discordant. So depending on what geographic area you're in certain cases in our Southern Belt, it can be as many or as high as 1 in 2.5 people show up language discordant. And so I'm here today because to me it really matters that the patients who are showing up are getting equal access to quality health care, and that we're evolving as a world and as states and as a region in order to provide that.
It's on.
Oh, is it?
Yeah.
Okay. Hi, everybody. Sebastian Sager. Adamika, thank you so much for having us. I'm the CEO of Scene Health. We help people take every dose of their medication correctly as prescribed. And we do it with a video platform it's not live video, it's actually video recording. So patients video record themselves through our application, telling us how they feel, taking their medication, and our nurse will review that and send a video right back. Sounds really unusual. It's also now the standard of care for certain infectious diseases in the entire public health system right now. So the CDC in 2023 took this process as as equivalent to an in-person visit. So it's the first time an asynchronous video message was made equivalent to an in-person visit, which is pretty interesting. The South, it has always been important for us since we launched in 2014. Our first customer was Harris County, Texas, which is the big rural loop around Houston. I think that county pretty much sums it up. It's 1,700 square miles. There are people who, have to drive half an hour just to get cell reception. So I think you have this combination of rural, low access areas combined with a growing population. Whereas I think like the middle of the country has, very similar problems, but it's just a lower population density. And that creates a lot of challenges. I know that in some states in the South, you won't even have a primary care doc available. In some regions of Georgia, you don't have a gynecologist available, so expectant mothers have massive challenges and high mortality. Not to pick on one particular state, I think all the states have challenges, but.
Sure. Go ahead.
Thank you, Health Tech for Medicaid, for having me here and all of our panelists today. I am Laura Harker. I'm a senior policy analyst at the Center on Budget and Policy Priorities, and we're a nonprofit research and advocacy organization. We really are focused on making sure that we advance programs at the federal level, at the state level, that make sure everyone in this country can thrive. And that's why I think the South is such an important place to look, because coverage gap, I know that came up in your opening remarks. That's something we talk about a lot. A lot of people don't realize how many people are left behind in terms of being left out of programs like Medicaid. We also work on SNAP assistance, food assistance, cash assistance. Many of these programs are really restricted or limited in southern states, and they're the places where the need is the greatest. And my own home is in the South, so I have a personal connection to just this issue. I love the South. I lived in Georgia for a while and worked as an advocate there on trying to get the state to expand Medicaid, which they are still one of the 10 states, unfortunately, that has not gotten there. But also I'm from North Carolina, from a rural area, and was born in a small rural community hospital, and just the importance of that community and that infrastructure in the South for healthcare and Medicaid is just personal to me as well. So excited to talk today about this issue.
Nice. Hi, my name is Dr. Kiara Robinson. I'm Vice President of CHW Operations at Waymark. So at Waymark, we combine patient-facing care with technology to be able to deploy CHWs, care coordinators, pharmacists, and therapists to provide that wraparound care for our patients that we cover for Medicaid. I'm super excited to talk about this topic because CHWs are sort of a rising force in Medicaid in reaching those underrepresented or underserved populations. And it's exciting to talk about how we can deploy these individuals in rural areas, especially the South, and combine that with technological advancement and ensure that these individuals who live in these rural states or rural communities are receiving the quality of care that they deserve.
Hello, everyone. My name is Kobe Takeda, co-founder and CEO of PearSuite. At PearSuite, we're building an AI software platform for community health workers. We love empowering them, supporting them, training them, deploying them, and helping them work with health plans. I think for far too long, they've been working for free, not getting compensated by the healthcare system, not getting supported, left to do work sometimes as volunteers or promotoras. And now this is the time that they can finally get the value and the recognition that they deserve. Who knows what a community health worker is here? Because amazing, that's awesome. Yeah, we're both happy with that. Anyone?
We have like a community health worker corner over
yeah,
there.
we really love community health workers. Anyone actually know a community health worker, where they've been a community health worker or been out with one?
Yeah.
That's amazing. Yeah. I mean, it's, everyone knows now, I think, about the definition and they kind of recognize the value. But actually to spend some time in the community with a community health worker is so valuable. I mean, I operate, even though I'm the CEO, I go out and do work alongside of my CHWs, and it's just amazing to hear the stories and see how they operate. They build trust, they get to know people, they know about their culture in the community, and it's just truly amazing. But at PearSuite, we are building software for them. We recognize the need for so many solutions that address things like compliance, credentialing, claims, being able to contract with health plans, and all of that can be solved with software. And so we're building software now. We have customers across 25 states, including a lot of states in the South and Southern Belt. We also have a provider network now. So anyone who uses our software can also be part of our provider network to get support from our claims team, our billing team, our contracting team to now work with health plans. And we're working with 15 health plans now. My background myself, I used to be in the aging space. I used to work in senior living and was teaching community health worker courses during the pandemic. It was a time when there was a lot of excitement and funding going to training. So that was amazing to see. And I was also working for the Blue Zones project at the same time. So being able to combine the Blue Zones project where, health and well-being was so important, and food, housing, transportation, all of the social determinants of health were tied to this amazing workforce that was being deployed. It kind of all clicked. And so that's where we started PearSuite. Like Amika mentioned, we have an office in Tulsa, Oklahoma. I have a place there, and we do a lot of work across the heartland. So I love going up and down Kansas and Oklahoma, and people are very confused when they see me, and they're like, this boy from Hawaii, because I'm originally from Hawaii, now living in Tulsa. But it's been amazing. So much experience and wisdom and great talent and skills here in the South, and these community health workers are making a real difference every single day. Thank you.
Great. So I think before we kind of get into innovations, I want to do some building blocks with you around policy. And I think that the reason why that's really important is that I think policy, specifically around Medicaid expansion, is something that's really important for folks to understand without understanding kind of why that's critically important and how that impacts the quality and duration of people's lives, and how is that so different? Can you really explain why Medicaid expansion in the South is such an issue, or why it's not expanding in the South is not an issue, or arguments on either side? And so, like, what does that actually mean for folks? Because I think we talk about expansion, but often people don't really understand what that truly means to folks' lives in the South.
Yes, there's so much with Medicaid expansion that has an impact on lives and on the healthcare system generally in states that have expanded. We've just seen so much federal funding come into those states to infuse their healthcare systems with dollars to stay open. If you're a rural hospital, which we know research has pointed to rural hospitals being more likely to stay open in states that have expanded. Individual lives have been impacted, lives have been saved even by expansion. There's studies about tens of thousands of lives that are saved when people gain coverage through expansion. And I think the issue is really just looking at the states that are left that haven't expanded, and the fact that 6 of those 10 states are in the South. And there's just a lot of history there with some of the decisions and political reasons and all kinds of reasons there. But really, the fact of the matter is the evidence has shown Medicaid expansion does benefit communities. It helps to bring at least $1 billion plus into states that haven't expanded. They're leaving on the table right now. That's federal funding they could use to invest in better workforce and to keeping hospitals open across the states that are left to expand. And I think also just thinking about the investment in those hospitals and how much impact they have in terms of economic impact broadly. There's some research also about hospitals and how they are a huge economic driver in communities, especially in rural areas, where a one hospital job created could lead to 2 jobs in the surrounding area. So there's a lot of larger impacts, not just for the people that would gain coverage, but a lot broader than just the people who would gain coverage. There are about 2 million people left still without health coverage that are in this coverage gap that exists, or about 1.6 million. It changes and fluctuates each year, but there's still many people that are just without any coverage options because they make a little bit too much money for the Medicaid program as it exists, but they don't make enough money to get any premium tax credits on the marketplace. So those are folks that are mostly lower wage workers, adults, parents as well. People with disabilities are in that group as well if they can't get Medicaid through a disability pathway. So there's many people impacted by the lack of expansion in terms of lives, as well as the cost and implications of that as well.
Yeah, and I think it's one thing to really point out it's not just about the people and the lives, but also the impact of the health ecosystem and the health workforce. You know, 1/5 of all hospitals across the nation use Medicaid as their life support of payment methodology. So, and I think people don't really understand how much money that is that goes into hospitals literally staying afloat. It's a different mechanism of payment through the Bureau of Primary Care, which federally qualified health centers stay afloat. But that's also another lifeline of care pathways. Let's talk a little bit about the economic drivers. And I'd love to talk as we're going into innovators, right? As you guys are building innovative companies in the South, kind of the flip side of that is you're also potentially building jobs, right, for folks. So, can you tell us a little bit about either your company itself and either your solution that you build, but also like the economic impact that you can be driving as a part of your product, not just in saving lives through, but also building jobs if that's a part of what you guys do. And maybe I'll start with you, Colby, at the end.
Yeah, so just a bit about community health workers and what it takes to become one. In many states, there is no certification, there's no credentialing mechanism. You don't have to take multi-year course or get a degree. One of my favorite CHW partners says, "Education is great, but experience can't be bought or taught." And that really speaks to the power of community health workers having that lived experience that brings them power and gives them that ability to go out there and make change happen. And I think that's the amazing opportunity with community health workers. You can find people who are in high school going out and becoming community health workers. We work with quite a few high school students that we support. We have actually there's a high school in an area that has a class that's a 4-year course you take and become a community health worker. And every year you train, you go out in the community, work with clinics, and they're using our software and getting paid for that, which is truly amazing, right? Now they have a job going out of high school immediately. We work with barbershops that are now doing work. They're doing screenings while they're giving haircuts, and they're able to get paid for the work they're doing to ask questions around vaccinations, around screenings, around visiting your doctor and PCP and finding culturally sensitive providers. So I think community health workers is an amazing position and opportunity for people that want to go in a field that they're helping and using their experience to help others. We work with the reentry population as well. One of our colleagues, Joe Calderon, has spent 20 years in a federal prison and was released and is now a community health worker trainer. He helped co-author a book about community health workers, and now he helps other people who are re-entering into the community become community health workers as well. And that's just a perfect opportunity to become, find a career that really aligns with your purpose, your skills, and can create many, many jobs, and of course, support the healthcare system. I think that's a big opportunity for community health workers, right? How do we partner with health plans and providers and clinics and everyone in between to create impact and reduce cost of care? And that could really open up doors for other things like preventative care. So yeah, community health workers are amazing. We love them, and we're all about empowering them. And I think everyone else would agree as well.
Yeah.
Do you want to go ahead and
Yeah.
expand a little bit more about
Yeah.
Waymark's role in community health
I
workers?
feel like we'll piggyback off of each other all day today.
Yeah, I told you this is like the CHW rah-rah section here.
But yeah, at Waymark, we definitely like to, as Kobe described, use lived experience as one of our markers for finding individuals. And as with my role, I like to educate individuals of the community and sort of inform them that they are a community health worker and say, hey, tell me about yourself. And when I'm in atmospheres like this or at health fairs where I meet individuals and they let me know some of their background, or, I haven't been working because I've been, taking care of my mom or my family, and I'll let them know you are a community health worker. So I built into my workflows to be able to have training systems, sort of like Peer Suite, where we take that lived experience and we help them to get into the workforce and use what they have and what they know to be able to have a sustainable role. And we'll probably talk about this later. Providing community health workers with roles that are permanent and full-time with benefits is super important in terms of sustainability in this area. And ensuring that, they're not one foot in, one foot out. A lot of our programs in the past where Colby talked about, unfortunately, we got our 15 minutes of fame during COVID, where they were able to realize what our best practices are and how we can affect change in the healthcare system. But a lot of those programs were grant-based, 1 year, 2 year, 3 year. And when that COVID funding was no longer available, a lot of our workforce was out of work. So what we do at Waymark is we ensure that our CHWs are full-time employees with benefits. We even offer them packages in terms of having ownership in the company and understanding how that can, you know, change lives of individuals who have never had that opportunity. So I think organizations like ours have a really great position in not only expanding the workforce, but also just making it better and a better atmosphere for these individuals that are using, let's bring it back, Medicaid funding and the funding that we get working with these different organizations to expand the workforce.
Yeah, that's great. What about you, Sebastian?
So on the community health worker theme, what we do, which is help people for a certain amount of time take their medication every day, was a community health worker process in public health departments.
Mhm.
And they would go out to people's homes and make sure that they took their medication. And through technology, they've been able to basically scale up because the workforce that was there was not able to handle and implement this process. We also serve the Medicaid health plans, help people with asthma, diabetes, hypertension, sickle cell disease, HIV, any chronic condition. And to your economic impact, I would say a couple points. So like the CHW example, the care that people get, especially in communities like we're talking about in the South, it's not enough to just see a doctor every once in a while. Everything that's happening in between, your community health worker is bridging a lot of miscommunication, things that have to happen that will never happen in a 6-minute appointment, with a physician or a nurse practitioner. We have a similar dynamic that we're helping somebody fulfill the physician's orders in between those visits. And here's the economic piece of this. The medications that are out there for chronic conditions are absolutely excellent, and they tend to generally be more and more expensive. If they are taken, people will not get as sick. They will not land in the hospital as often. So it's at least 30 to 40% of admissions and readmissions are due to failures of medication, whether it's not taking them or taking the incorrect ones. That can be straightened out. People just need a little bit of help. That's hundreds of millions, billions of dollars every year that are spent. Probably the one that's more relevant today, though, is that Medicaid spends $50 billion a year on prescription drugs. That's after all the rebates. And we know for a fact that at least 30 to 40% of that is pure waste. It's just not going to be taken. It was prescribed, picked up, never taken, wrong medications, wrong formulation. That waste is a massive opportunity because if taken as prescribed, people will not end up in the emergency room in the hospital, which is actually what we really want from all this outcome. So I think in terms of economic impact, yes, as we grow, we create jobs, but hopefully we keep people out of the hospital so that they can go to work. And fact of the matter is, we're living in a time where budgets are not going to necessarily be bigger. And this medication spend is a complete and total boondoggle right now. I mean, there is no way that we spend twice as much as any other industrial nation on our medications. It's not possible. So we can eliminate that waste.
But it also sounds like if in the South we have less emergency rooms, right? That there's also a reduction in, burden to the health ecosystem, right? By having less inappropriate, opportunities for people to go into the ER or, have any other ill-fated, issues around medication complications, et cetera.
You're saying that because there isn't access, then they're not going to end up there. Yeah. Right. Yeah, there was a great study on preventing readmissions for people with CHF, and some of the most effective strategies.
People what CHF is.
Oh, congestive heart failure. So they put a readmissions quality target on CHF. This is in 2018. And the best strategy for reducing readmissions was to not have them go to the hospital. And so they ended up dying more often. So yeah, I think these communities have very high mortality rates. And so not having access to emergency rooms or other sources of care is going to end up with people dying or having more serious conditions. And we don't want that either. It's also not economically, for an industrialized nation, it's a complete shame, right?
And when you manage conditions with your medication, you can then spend your money on getting a job, right? Or spending money on better food, enjoying recreation, supporting your family, and that's other spend as well. So addressing
Yeah, I mean,
social and health
I
needs.
always say this is like my favorite tagline, which is like the largest economic indicator in this country is being healthy, right? If we're healthy, we can contribute to society. If we can contribute to society, we can make this nation great, right? But we have to be healthy, right? We have to. And that's not just about medications. That's about our mental health, our physical health. That's being affirmed, right? That's being psychologically safe. There's a lot of things that go into being healthy.
Right. On the just last point on that one, which is a great point, people with chronic conditions who have control of the condition cost a lot less.
Yeah.
It costs like a half of what someone with out of control chronic conditions cost. So we have to work on the outcomes.
It's a great way to talk about people being affirmed through language.
Just go for that one. That's a big one. Yeah, I mean, we watched that one of the greatest contributors to people not. Let's start with the entire patient journey for a second. You might have heard this in my last presentation, but when we look at the impact of language barriers on how a patient kind of takes their journey, patients who are limited English proficient, they are, exponentially like 200% more likely to get an adequate preventive care. So they're already more likely to kind of end up in a situation where they need care. And it makes sense, right? You're my patient, I'm your caregiver. If we don't speak the same language, which happens in hundreds of thousands of conversations every single day, you can't understand my symptoms, so you can't diagnose me correctly, you can't treat me correctly. You mistreat me, I don't get better, I don't trust you, I miss work. Like there's just a waterfall of terrible outcomes from that. And so as we go through that journey, I'm inadequately, preventively cared for. I get mistakes made as an LEP patient in my intake process more than anybody else. Throughout that process, I'm increasingly more likely to readmit. I'm less likely to get better. In fact, I'm 30% more likely to have to come back because 700% of the time, the discharge instructions that were given to me did not kind of meet my expectations, and they were not understood. And so we see so much of that in terms of patients wanting to just kind of feel affirmed and like, you see me, you know me, and part of that is meeting me linguistically and culturally. And I mentioned earlier there was a study from Banner Health, and they were looking at patient satisfaction, to your point, Adamika, about how do you affirm through language. And the patients, when they were rating their care experience, it wasn't about the care they had gotten. It was about being seen and heard as a human, and really kind of feeling like, you're speaking my language, pun intended, but, I'm here and you cared enough about me. So, we're obviously incredibly concerned about this. We serve about 220 languages a month and hundreds of thousands of conversations. The impact of eliminating those language barriers has been huge. And the fact that we can do that in many cases and mobile now gets us in lots of other use cases that become really fundamental to this process. So we're meeting patients more where they are. And, I think we are affirming.
Well, let's talk a little bit about the kind of what I would say the elephant in the current room, right? We are in a interesting place and time in this country where we're not talking about equity, right, or health equity. We're talking about equity as in money. We're not talking about equity as in health equity. Fascinating. But when we're talking about it in the context of the South, we are talking about a region of the country that is more racially diverse and is more poor than the remainder of the country. And so I want to know a little bit more about how are you guys addressing, either through your policy work and or through your innovations, the specific or unique needs of the Southern Belt populations? Or if you're not addressing that, how do you want to be, co-designing or, co-working with folks in the South? And then we'll go back from there. But I want to start with you from a policy perspective, because I think it's a good framing way before we get into the innovations. The South does look different than the remainder of the country, and in this particular climate, and we don't really know what this climate looks like. We're 20 some odd days in. Um, but I think that, we're feeling a little bit like with health equity, kind of the term being under attack. What does this mean for a more racially diverse part of the country, and potentially a more financially fragile portion of the country?
Yes, that's a big question for us just because we know the impact Medicaid has had in advancing health equity through some of the advancements in the last several years. For example, extending access to postpartum care has been something that the previous administration did that has been helpful and to address Black maternal mortality crisis, which is also very acute in the South. The One of our top policy priorities, as is in our names, policy priorities, one of our top priorities is Medicaid expansion because of the fact that over 60% of the people in the coverage gap are people of color. So they're much more overrepresented. And we know that's because of discrimination in the job market and as far as access to types of jobs that offer health insurance. We know that differences in wages and income that have resulted from historical systemic racism and discrimination and bias have contributed to the fact that more people of color in the coverage gap, and solutions like expanding Medicaid would really disproportionately benefit communities of color to have access to care. We also look at other issues as far as Medicaid helping to address issues like mass incarceration, which is something that states have been able to use Medicaid to invest in. I know you talked about reentry a little bit. States are investing in criminal justice through Medicaid, using different types of Medicaid waivers to provide care to people who are incarcerated and to also smooth that transition when they are reentering back into the community so they don't have a gap in healthcare when they enter their community and can be healthy as possible. So there's many factors within the work that we do and what we prioritize within Medicaid that is really important for the South and for advancing equity overall, just because we know how beneficial Medicaid is for communities of color. And also Medicaid is really popular as a program. I think we often hear about cuts to Medicaid that are being proposed right now, and the fact that Southern states, some of them haven't expanded, there's the thinking that people aren't supportive of Medicaid expansion, but polls have shown Medicaid and Medicaid expansion are very popular. A lot of people, there's recent polling actually from KFF that showed most people have either had experience being on Medicaid or they know a close friend or family member who has benefited from Medicaid coverage. And we know 1 in 5 people are currently served by Medicaid. So it's such a broad reaching and important program that is really popular and people don't want to see it cut, but we are hearing those proposals now.
And it's interesting because Medicaid has often been, now there's been ups and downs in this, but it's often been a bipartisan, acceptable program. I mean, maybe it didn't start out that way, 60 years ago. Medicaid's turning 60 in July. But, because it started as a women and children's program. But, there have been much of the time it's really been acceptable on both sides of the aisle. One thing I also think that is interesting to stress is that much of the Medicaid expansion we have seen, especially in the South, has really come through ballot measures. So can you speak to like that sort of angle, a little bit different than maybe just the governor just saying we're going to do Medicaid expansion? It's like the people have actually pushed for expansion of Medicaid.
Yes, that's been really the place we've seen the most movement in terms of states expanding post 2017, 18. A lot of states initially expanded in 2014 when the option became available, but those later expanding states, a lot of them, it occurred through a ballot measure where people in the state signed petitions and they wanted to see this issue on the ballot and to vote on it. And 7 states have had ballot initiatives on Medicaid expansion, and all 7 states, Medicaid expansion won. So it's also clear there from that evidence evidence that Medicaid is popular. South Dakota most recently was the seventh state where they had their Medicaid expansion through a ballot measure. But the interesting part too is that many of the states that are left to expand don't have that option available to them to do a ballot initiative. They have to have the legislature approve anything going on a ballot. I know states like Georgia, for example, that's required, but some states are looking at the option of a ballot measure. Florida is trying to do an initiative in 2026. The Florida Decides Healthcare Initiative to put Medicaid expansion on the ballot then, but they're also facing a lot of hurdles. They actually have to get 60% of the vote to approve expansion if on the ballot, which is a higher threshold than basically any other state, one of the more strict thresholds. So I think that's another place. Mississippi, they've tried to do a ballot initiative there in 2021, but the legislature basically shut down that process. Just as the advocates were getting close to getting Medicaid expansion on the ballot, it was shut down by the legislature. So I just think just the higher thresholds around trying to get it, the harder it has been getting to do ballot measures. It's really like shutting down that voice where people are saying we want to see expansion, but shutting down the opportunities to do that is something we're seeing happening in several of those southern states.
All right, I want to thank you. I think that's just a really interesting framing as people really understand why and what that means. For those of you guys who are innovators, right, you're private companies, you can kind of do what you'd like. You don't have to necessarily change your website. I'm just being real here. Let's be real. Right, you don't have to change your website. You don't have to change unless your investors are pushing you to do so, and it'd be fascinating to hear that. And maybe your investors are pushing you the opposite way. That would also be an interesting conversation. But we are in this time. We're in a time what I would call frantic panic, where folks are really worried about the word health equity. Staff are coming into work wondering what this means for their job, if health equity is in their title or in their job description. If health equity is anywhere in the work that you do, and I know all of you guys have it deeply on. I've checked all your websites out. I know all of your CEOs. You are CEO. So I'd like to know what this means as an innovator in this time. And I recognize this is taped, so if you don't want to really speak on this in public, but I think this is something we need to really be talking about. And specifically as we're looking at populations that are more diverse and definitely do not have a lot of resources. So I'll open it up to whoever wants to speak about this, if you're able or willing, and then I actually may just open it up to the audience, and we can maybe start to have some general conversations as we talk here, and if you guys are open to that, and then we can come back to some more innovator related questions and see if there are things that I haven't asked that people want to hear from. Does that work for you guys? Okay, good. All right. Anybody want to say something?
I'd love to dive in on the equity question. I'm sure Cody does well. First, this is the time where private companies should speak up. So if we don't have to delete, and we're not deleting, in fact, we've come out very kind of aggressively saying we're unabashedly still fans of health equity. It's in our mission. If you want to work for our company, you have to believe in that. That has to be why you're here. It has to be the good work that you're prepared to do. We blast our mission statements all over the, as you say, our website, our material, but we live it. It's still in our DNA. It's still kind of, it is the driving force. We are a, doing well while we're doing good organization. And this is why we do the work. We believe that eliminating language barriers actually gives healthy access to more people. So I think private companies do have to speak up. Not that this is the topic that you asked about, Adamika, but I think it's a great lesson. And I'm sure Cody can echo that when you're picking investors, all money is not the same money. So picking investor partners who believed in this from the beginning is really important. And we were very fortunate to have investors that we had talked to right at the beginning who believed in what we were doing. They still believe in what we're doing, and they're supporting that. And now we're really kind of looking at much more expansion. We do look at, when we think about the South and we think about how do we innovate, how do we solve for some of the kind of like more public policy innovations, what do we do? From our perspective, from language, we see that language is so critical in even talking to people to figure out what problems we're solving for. is a great example of Duke Health. They were looking at kind of some of their chronic disease categories and noticing a lot of patients weren't showing up for appointments. They hired interpreters to call these patients and ask them why they weren't coming. And the patients kind of answered, and the result of that was they created 11 new bus routes in their neighborhood to get patients into their hospital center. Chronic disease rates went down, and they were also able to kind of develop a better, more stable and trusted relationship with the community. So even just having conversations with the community to understand what the problems are that we're solving, you need language. And then, you need language if you're going to actually kind of help people to have better health care. And we do that with kind of virtual interpreting. Other companies do that with virtual interpreting. But we think it's actually important to put these tools not just in the hands of care providers, but also patients. We have to trust patients to be in control and to be empowered to take care of their own health journey. So we think that's really fundamental. And I'm sure we'll talk about AI at some point, but I think there are positives there for how we do help health equity. And I think that there's a lot there that we have to be very careful about how we kind of, create some guardrails so that, we don't have too much bias built into that AI as well. But
I do want to just preface this with, and I don't want to put anybody on the spot, but like we're still early on this journey, right? And so if you do take federal funding or you do have federal contracts, you are going to be obligated to change language, do some cartwheels, do some contorting. Just going to be real. Some states may have to comply with federal compliance depending on the state's stance. And we haven't seen that really play out yet. We're still very early in this game. And I think that's having this conversation today and having this conversation in 6 months and having this conversation in 36 months may all look different. So I just want to put a pin in this and just say, like, this is how we all feel today. I don't want anyone to feel like they have to go back and, retract anything. But I do think that it is a big issue when you're thinking of serving and are serving in the southern region where it is a more diverse population and a poorer population. And there is an attack potentially in this country right now on, looking at data that allows you to even define those populations. So I'm going to let the conversation keep going. I just didn't want anybody to feel put out.
I think the conversations will be different at the different checkpoints, but I think implementing those checkpoints is important. So we had this conversation at the table around, the health equity conversation and, what our organizations were doing. And super happy that Waymark is still doubling down on health equity, but creating those internal checkpoints for ourselves and our KPIs in terms of health equity being one. So are we serving X population at the proportion that they are in our system, ensuring that, again, they're not underserved and they're not underrepresented in what we do. But I think just bringing this topic to the table continuously is helping in terms of addressing health equity.
Yeah, and I have a specific question for you guys, specifically as you're dealing with community health workers, and just the word community in community health workers implies that they are coming from the community. Yeah. If you're dealing with community health workers who are coming from the community, and I'm speaking as an epidemiologist who did and have done community work most of my career, these are the people who are really concerned about their jobs. Let's be real.
Yeah.
And so you're having to come out the gate, I hope, and I hope I'm not leading here or lagging, but providing people with like literal confidence that the company's going to stay around, that you're not going to change, or, the tenets of what they kind of went to go work for a place, because, and you said it earlier, in COVID, we created a scaffolding for people, an infrastructure, and we told people these kind of jobs are going to be really useful. And then we kind of pulled the floor out from underneath people once the funding went away. And next thing you know, a lot of groups of people were completely outside of jobs because the federal money was no longer available. And so that class of worker was no longer valuable because we weren't doing community health fairs, and we weren't doing, testing sites, and we weren't, doing mobilization sites where we were going to people's homes and doing disease investigations in the same way. So maybe this is more of a personal tack for you guys, but like, how are you providing confidence for folks around being community health worker in these times?
Yeah, I'll just say that there's some exciting things happening around, of course, tied to funding, but reimbursement. And this is something that's new for a lot of the community health workers. Now can get paid through Medicaid and Medicare. We're also working in states where there is no reimbursement, but they're still getting paid by the health plans. And so health plans are saying, yes, we want to honor and support you. We see that you're doing amazing work, and we want to compensate you appropriately. Of course, a lot of that is tied to policy. But what I'll say is that we're doing a lot of work in states where policy doesn't exist. And then actually it's better for the community health workers because they can negotiate better rates. They're not stuck to the rates that are designated by the health system or the health plan or that's created by the state. But policy is obviously really important. I will say that back to the question around equity and the terms we use and whatnot. Community health workers don't turn this on and off. This is like their job. They're going to do this work even beyond funding stopping. I think they're born as to do this work, and it's their purpose, their passion, their skills, and a lot of the groups we work with are community-based organizations. These are groups that existed long before all this reimbursement and training and hype around community health workers started. And so when there's times of need, they step up and they go to the plate and they do their job and they create impact. And that's really amazing. Of course, lots of the is tied to, being able to sustain themselves and create that, funding stream that allows them to keep their jobs. And that's why the reimbursement conversation is so important. But we're actually seeing quite a bit of excitement in states, blue, red, everyone in between. Oklahoma this year is rolling out CHW reimbursement. And actually, it's kind of funny stories. A lot of the work around these more progressive states, it actually takes longer for them to roll these out because they have so many listening sessions and they're getting all this feedback, and it takes 5 years to get the policies in place, and then all of a sudden things change. Yeah. So it kind of goes back to the idea of like NIMBYism, right? It's harder to create affordable housing in places where they have all this board meetings and you have to get approval on this and that, where other states, they just do the work and they just make things happen. And all of a sudden you have a policy in place and you can get repaid. So we're seeing some exciting things happening in states like Kansas and Kentucky, where reimbursement exists and they can get paid now. Of course, there's other things that still are barriers, getting technology to submit claims, understanding how the reimbursement works. And that's kind of the things we do at ParaSuite. But it's exciting to see, this bipartisan support for rural health. And there's a really amazing, if you're in the policy space, there's a bipartisan rural health caucus. Is huge. And a lot of representation from representatives and senators from red states. And so we want to work with them. We want to partner with them. We know that some things might turn them off or on, but we, if we can work alongside them and show them the value and the numbers and the cost savings and the important work that CHW is doing, that data can really help them make a difference and make a change. If that reduces the burden on providers like nurses and doctors, they'll get excited. And all of a sudden, it's not less about the health equity. It's more about how do we increase access to providers and reduce burnout for these providers. So it's a tricky art, policy making. We can't not always hold signs and stand up for things that we don't agree with. We have to sometimes be strategic in how we work. At ParaSuite, we, even though we're a company and building software, we love policy and we love advocacy and we love empowering community health workers how to use their voice and speak up and share their story and talk about how they're making a difference and talk to legislators and that story can make a big impact. So we love going. We're actually going to the Capitol in 2 weeks.
Me too.
So, yeah, going for the natural. We're doing a Hill Day with CHWs, and so being able to help them use their voice and speak up is so important.
Yeah, my 2 cents here would be that I understand on the advocacy side that the language change would be a massive, massive change. I would say, though, that on the optimistic side, from the other perspective, which is delivery of services, my experience has been since we've been around for 11 years now, working in either public health departments or with Medicaid health plans or Medicaid states. Everybody who's in Medicaid, not everybody, but really the vast majority, really wants to have an impact and has chosen this sector for a real reason. And there's a lot of passion there, a lot of passion to help other people. And it's almost like a continuation of the stream of charitable care in medicine, which is a long-standing tradition in medical care. So in a way, the fact that certain vocabulary would change doesn't change the fact that the population has a lot of challenges. The population is as diverse as it is, heavily Hispanic, heavily African American, lots of people from other countries. In public health departments, 60% of people are non-native English speaking and recently immigrated. So those things don't change, and your approach to how you're going to serve those people also probably doesn't change, because if you're working in this space, you're doing what you have to do to engage, forge connections, et cetera. But the way you express your passion externally or to motivate your employees or the rest of it, yeah, that's hopefully not going to change. But yeah, maybe there's a real attack on the vocabulary that we've used to define something. But I would say it takes away nothing from the mission that's probably living in all these companies, right? That mission is likely going to continue, right? Medicaid isn't going away. Here's the other thing, which is really great also for health tech for Medicaid. I'll just say it again. I don't know that budgets are going to be the same. And the way you attack something like that is to be even more efficient, even though there will be compromises in care. Technology is an incredible means to gain efficiencies, and those efficiencies can be massive. I mean, really, the fact that you could pull in an interpreter into a conversation nowadays, just like this. It used to be a live meeting that had to be had. That's an amazing thing. I know is Rima, right?
Waymark?
Waymark, yeah. You're sending your technology usage is also scaling what you do, and I'm sure you'll have a strategy as well for that. So technology is a massive opportunity, but that's the optimistic perspective today.
I agree. All right, before I get to questions in the audience, and I'm hoping there's some there, I just want to ask you guys, and you can go as you please, any tailwinds or any headwinds that you're seeing that you want to see, either movement, progression, any hopeful things you're wanting to see and working in the South. And we'll take these back, because we certainly will be doing a lot of deep work in the upcoming years in the South. And so hopefully get to spend more time with you guys as co-conspirers in this work. But anything you're seeing as headwinds, and I know a few of you have mentioned some things, but like headwinds or tailwinds that you really want to mention, you want to see. Anyone want to start?
Clearly, I'm always happy to start. I think one of the exciting points, and I'm going to pick up off of what you were just saying, which with all the diversity, right, the increasing diversity across the South, I think poses exciting opportunity. And as we watch migration patterns, there's a lot of research that indicates that there's going to be heavy migration into the U.S. through to 2060. That's not just in the U.S., it's happening around the world as we've kind of watched super diversity kind of centers develop. But there's a lot of diversity coming into the country, and there's a lot of diversity that's been here. When we're monitoring that on a regular basis right now, our proxy is to watch the number of languages and the diverse languages that are spoken. It's not just a Spanish English challenge anymore. In fact, it's a whole bunch of rare and indigenous languages. And the hope there, the tailwind, is that so many of these states are kind of embracing their diversity and looking for having conversations around how do we support diversity. And so whether it's because it's just a reality they can't run away from, or whether it's a reality they want to embrace, they are having that conversation, and they're coming to us and they're saying it's not good enough to just do this. Like, we really have a bigger group of people that I'm going to say that we have to put our arms around.
Love it. Thanks. Anybody else? It doesn't have to go in order.
First.
Oh, this way?
All right, whoever wants to go. It's all up for grabs.
I'll go. I know we've talked about CHWs a lot here, but that's sort of my passion. That's what I've done for the last 11 years. That's where my research is in. And I'm really excited about Medicaid in the health field getting to know us and understand how we can benefit this healthcare space, and also how our work can pair really well with technology and AI and machine learning, and how we can all work together to, again, increase the quality of health for the patients that we serve. So I'm just super excited about some of the conversations that we'll have next week, at the Capitol, or speaking to legislators and developing these CHW associations in the different states who help us rally and talk about financial reimbursement. So I'm just super excited about CHWs and promotores and other individuals who, like I said, we're getting our 15 minutes of fame, but we've been here for a while. And I think everyone will understand how pairing us on healthcare teams will really help with that ROI and, again, help patients just be healthier in the long run.
Love it. Thank you.
Yeah, I'll just add that, despite the environmental and political landscape, I think people are stepping up, right? Health plans are stepping up and saying, we still believe in this. We're seeing foundations and corporates and, organizations say that we still want to invest in this work. Our software does a lot of work with doulas as well. And we're seeing a lot of interest in, despite policy and restrictions at the state or local level, we still have to get the job done. We still have to address health needs. We still have to improve outcomes. And if it's tied to claims and cost savings, then people will invest in this. People will see that there's a potential to make great impact. And I think that's still a bright spot for what we're seeing in the landscape. And I think the data, the numbers, the technology will help us make a better case for this. And we'll be able to make people that have decision-making power change their mind and hopefully make some good things happen. So
Amazing. Anyone else?
I would just say, even in the states that haven't expanded Medicaid, there have been a lot of progress in those southern states to use Medicaid to make investments and innovations. There's several states that stand out to me. North Carolina, for example, using Medicaid to invest in housing supports and nutrition supports. Their evaluations have shown it's actually been a savings for the Medicaid program because you're reducing hospitalizations and other adverse outcomes by providing those social supports. I know Louisiana, they've done work around community health workers, and they've really brought together policy advocates to help educate community health workers about how policy works, how state budgets work, so that they can be engaged in the process of making sure reimbursement rates are adequate and that the policies are implemented in the way they need to be. There's a lot on maternal health that's happening in the South, where states are using Medicaid and bipartisan investments and agreement around investing in maternal health. So also just the organizing and capacity around power building that's happening across the South to really just bring the voices of people with lived experience to the table to really make those decisions in Medicaid and bring that informed experience.
Yeah, I was going to say, I think the long haul, if you know much about the North Carolina experience, many of us I have lots of gray hairs and a big patch back there that are dedicated to North Carolina. It was a long haul to get North Carolina to expand, whereas Louisiana was a completely different experience. It was quite easy for us to get Louisiana to expand Medicaid. But because we got North Carolina to expand and the way it was done, the amount of money and time and energy and the extreme quick wins that have happened in North Carolina, I think it's really interesting anchoring how the rest of the South is actually looking at why are they getting so much attention? Why are they getting so much money? Why is it, and so it's been really great, I think, in my mind, to see additional attention being had.
Yeah,
on the
Georgia, we were always like, as long as we're ahead of Mississippi, everyone wants to not be the last. So everyone's kind of looking at each other.
Well, and I'm also really excited about having Drew Snyder as the CMCS director in CMS, and so having another state Medicaid director inside the four walls of CMS. I mean, we had Daniel Sy, but it was a very different administration. Daniel's coming to San Francisco, but it's a very different type of administration that Daniel worked in. But having a Southern state Medicaid director inside the four walls of CMS, specifically Mississippi.
Yes. Not to say anything bad about them.
No, specifically Mississippi. It's fascinating. And that, I think, will, one, have attention specifically on the South, but two, I think it'll be very eye-opening for all of us to start to get some attention for the first time in the South in a way that we haven't before. Anybody else?
Yeah, tailwind, I would say, you said it, ROI, return on investment. The pressures are there over the last few years with interest rates higher, with redetermination hitting MCOs really hard to demonstrate return on investment. And the fact of the matter is that in the South, you have a large segment of the Medicaid population that is high utilizing. Mm-hmm. They're on a lot of medications. They have comorbidities, multiple chronic conditions, and the opportunity there to control those situations by helping people with community health workers in their home, or by making sure they understood their discharge instructions or they're taking their medication correctly. The opportunity is massive, and it can, if you have the ability to do the health economic analysis, it can show a good return on investment. And that is what will keep companies like ourselves and other innovators in business, in the economy that we're in right now and we're about to go into. And I think that if you look back 5 years, it was a different story. The economy was more flush with cash, and there were different principles that were important, like engagement. That was the only question I was asked was, Sebastian, can you engage this population? Yes, we can do it. Show great engagement. That's it. Now it's, what is the return on investment going to be?
Great. I'm going to let you guys stay up here, and I'm going to see if anyone in the audience has any questions. How about that? Any questions? All right. A good Georgia girl over here. And innovator. Tell us a little bit about wellness while you're at it.
Thank you. Thank you. Hello, everyone. Thank you so much for this amazing panel. Shout out to Kobe, fellow Techstars colleague over there. I have two questions. First, let me just lead by saying thank you for the inspiration and the hope, because I was one of those people who reached out to Adamika saying, hey, what's going to happen? Medicaid, oh my God. So thank you for the tailwinds, the hope, and the inspiration to know we will continue this journey. We will make it happen. The first question was really directed towards Kobe, and I wanted to know, like, what health plans have you seen are really open to covering stage Ws, and is it under a value-based model? Both. Sorry. Yes. And Kaliria, am I saying it right? Kiara, sorry. Yes, to both of you. What health plans are doing that? Is it us moving from FFS to value-based model? And then my other question was, how do you get MDs to really want to tap into taking Medicaid and Medicare? And, what is, sometimes you may find someone who's not willing to do it. And is it just only finding passion driven? I mean, you want everyone to be passion driven, but how do you get them to, like, hey, there's more here, like we can make this work type of thing?
Sebastian may want to chime in on that one too.
Yeah, I think health plans have a goal, right? To serve their members and either make money or save money. And if you can tie what you do, and it kind of goes back to the ROI piece, right? If you can show how the work you do, whether it's CHWs, doulas, health education, online apps, this and that, if you can tie it back to something that makes them money or saves them money, they're interested. I think there's always gonna be someone at the organization, whether it's CFO, CMO, health equity officer, whatever it may be. They have goals to hit, and if you can tie it to that work, you probably can get a meeting. Then the mechanics comes in play, right? Can you actually contract with them? And that could in itself be a legal battle, right? Going through contracting, vendoring. Can you actually find a way to submit claims? That's another potential challenge, right? And that's why ParaSuite exists. We help organizations that previously couldn't contract and meet compliance requirements, get claims, get cyber insurance. We help them do that with our team, reducing those barriers. So all of a sudden, these health plans who previously didn't want to work maybe extra to make this happen, if we offer them a turnkey solution, they're more willing to talk, right? If you tell them that you don't have to change your processes, you don't have to build a new team, you don't have to co-develop with us, this and that. You can just turn it on, and all of a sudden you can create impact and save money, and you can show them the data to help them realize that value. That's golden. So look for opportunities like that. Find champions, find hero people that are at these conferences who are looking for innovations and different ways of doing things. I always tell people, ask them what their problems are. What are those big, underlying pain points that they want to solve for? And see if you can tie what you do to those problems, because that could be a good way in. I think every health plan is looking for ways to save money. I mean, if you saw any of the stars ratings this past year, people lost millions and billions of dollars just on those alone. Tie what you do to those, and you can probably get in.
I'm glad Kobe went first, because I had to, think about what information I can share. But I like to point across, all health plans are looking, to work with CHWs or with a program similar. Piggyback off of his discussion around, like, what are they interested in their CFOs and finances. But you also have to remember that we're all here at this conference. At a lot of the conferences that we join is to make sure that the patients are getting and staying healthy. So advocating for that health piece when you're in these meetings as well. And a lot of people don't know that a lot of health plans actually have their own internal CHWs. So organizations like Kobe's and myself, we kind of bring in, like you said, that new perspective. So maybe they have CHWs that are strictly virtual. So my company can bring in something different. We are in the community, we're in the field. We visit your patients at the hospital, we visit them at home. We go with them to their doctor's appointments. We ensure that they understand their discharge plans. If we do need translators, we connect them to that as well. But I think all health plans are interested in any type of program that will keep their patients healthy and provide them with the education to essentially stay healthy. I always say, as a CHW, our role can kind of be encompassed in education, navigation, and motivation. We have to educate individuals and stakeholders on what we do, how to work with us, how to incorporate us on their teams. We're not just navigating patients, we're navigating health plans and understanding, how they can work with CBOs and work with the communities and invest in communities to keep their patients healthy, and then motivating not only stakeholders but our patients to understand how to become drivers of their own health, and then also motivating these health plans inside of these business meetings to give us some funding to be able to do so. But I think all health plans are interested in programs like these, and I'll kind of bow out of that second question about the PCPs and Medicaid.
So the second question was really about physician leadership and how do you get, I hope I'm wording this right, how do you get clinicians to like be more open to taking Medicaid, like physicians on your leadership team or as a part of your ecosystem with your product?
So from our side, since we're only targeting public health and Medicaid and Medicare MCOs, anybody on our team has signed up for that mission. So there's no, in the interview process, you've got to want to make an impact in these communities. So that part is pretty simple. I would say that maybe the problem isn't as dramatic since we're in augmentation. The health plans implemented us. The provider that the patient has is seeing a Medicaid patient. So the bigger challenge is not whether they accept or don't accept Medicaid. The biggest challenge is to get them to pay attention. And that's not necessarily their fault that they're the provider's hard to reach. It's more that they're bombarded, right? Providers today, there aren't more providers than there were. There are fewer. There's more people out there, and there's more territory to cover. So providers really have a hard job. So you have to put a provider in front of them to get their attention. So we tend to communicate with physician providers with our pharmacists, for example. I don't know if you guys have more to say on that.
Yeah, our providers are already working with the health plans that we work with. So they are already taking Medicaid patients.
Yeah, I could just add from the policy perspective, of course, beyond obviously raising reimbursement rates and the need for states to do that to attract more providers. I know there's advocacy that can be done to make it faster to get payments. I know that's also an issue that's come up in a lot of states, really streamlining the process around payment for providers. And that's going to be even harder if there's cuts to Medicaid with already strained agency capacity to make sure that those payments are timely. So really making sure we are making investments in increasing state agency capacity and Medicaid so that we can focus on improving the participation rates among providers as well from a policy side.
Hi, everyone. Thank you so much. As we talk about community health workers, another role that I'm really interested in are certified peer specialists. All 50 states now have some form of certification, a newer national certification having rolled out. What opportunities and challenges do you all see in working with certified peer specialists? How do those work with CHWs? And what does that look like into the future in terms of Medicaid innovation?
I'm excited. A number of the CHWs that I work with are most likely certified peer specialists. So they bring in a different perspective, they bring in a different level of experience. So super excited about working with them and learning from them and sort of combining the competencies and the best practices of both roles and sort of making like a super CHW role here at Waymark. So I love working with peer specialists, and that's that education piece where they may have been a peer specialist last year, and understanding the experience and the education that they have makes them a perfect fit to be a CHW and sort of address the holistic care for the patient.
Yeah, I'll just add that every state we're seeing some challenges and with adoption and funding for training. I mean, we do a lot of work in California as well, and we're seeing sometimes there's more excitement around CHWs. All of a sudden, the next month it's more excitement about peer support specialists. That goes across the health plans as well. Like, what are they willing to contract with? Is there standardized codes or training or credentialing policies in place? And that's kind of the challenges with CHWs now because it's Medicaid, state by state. Every state has their own credentialing, contracting, policies in place, and the variability is confusing sometimes for people, and it could turn people off. But yeah, I think if states want to invest in any workforce, right, whether it's doulas, community health workers, peer support specialists, not just looking at a credentialing and payment mechanism, but the training, the education, the technical assistance, supporting them with software expenses. These are things that could be barriers, if not. And so investing in the whole ecosystem and that wraparound support is so key as well.
I like that. We work in different states where we have one state who has a robust CHW certification process, and in Washington State, they don't. You can obtain a certificate, but not essentially be a certified CHW. So finding different ways, like you said, to train individuals, maybe Pear Suite or other organizations. I'll join different trainings so that I can bring that information back to my CHWs. But also if we have a CHW who wants to become a certified peer specialist, providing that funding and that professional development fund to expand their knowledge and, allow them to increase their education levels. And yeah.
First, I want to say thank you for everybody, all the work that you're doing. It's very impressive, and it very much aligns with the kind of work that I like to see, and one of the main reasons why I come to the ViVE conference. My name is Daniel Turner Lloveras. I'm a physician. Also founded the CEO of the Latino Health Innovation Alliance and Salud Contec. My question to you all is a beautiful example was given about North Carolina, and it showed how investments in Medicaid interventions involving housing and nutrition led to real outcomes like reduced hospitalizations, things that we can actually measure, things that have value to everyone. Given the current political climate, and I heard someone had brought up the idea of health plans stepping up, what type of data or what other types of outcomes would really convince health plans to really step up and try to fill the gaps that we're now seeing that may form as decreased funding in Medicaid is happening? And then also what kind of outcomes are needed in order to turn these pilot projects into really long-term sustainable Medicaid integrated programs?
I'll start small. I'm sure these guys will go very big picture from here, my little tiny world of language over here. One of the things that it's been very exciting to kind of look at different tests and pilot opportunities where we've been looking at the impact, and so kind of showing the ROI to our clients and showing them like what happens when you actually reduce language barriers. Well, 56% of malpractice cases, contribute or because of miscommunication, or we show them all the inefficiencies if you don't understand your patient, let alone kind of the, increased morbidity and mortality. And so when we start making it very financial, obviously, as everyone has set up here, that's what resonates. One of the pilots that we did with Mass General Brigham was actually showing very concretely if we it was a pediatric, a ped-onc, clinic where we were showing the impact of putting interpreting in versus not having it. And we were able to see like significant results in efficiency, cost savings, and patient outcomes. I won't get into all of those, but we documented that. And what was interesting is like, yes, that's something that we wanted to and shared with kind of payers and providers, but it caught the attention of the hospital. And so they start also seeing kind of, it's very real for them, not just kind of, what's happening kind of broader in the, regulatory ecosystem, but very real for the hospital to have understood, wow, if we do more of this, we as a private organization or as a public organization or as a quasi-public organization, we can actually kind of get more of those results ourselves. So sometimes it's actually bringing that argument into kind of more of a micro space and letting people see that, and it doesn't have to just be like a broader payer, conversation. One other quick example is we actually gave patients the interpreting in their palms to kind of go use when they wanted to, and we said, go outside of the hospital, take it to the gym, take it to the grocery store, take it to your rehab center. So it was beyond just kind of like what was their, hospital or doctor's appointment. And when we did that, they came back and they reported overall better health and higher quality of living just in general, because they could communicate better throughout their lives. So again, small little world over here in language, but I think that there are a lot of cases to be made to give, private organizations, let alone kind of, the greater kind of public regulatory market, real efficiency ROI data that will encourage them to take these steps.
Yeah, I think a health plan is a risk management organization. So they do have their case management team, and they're going to be building provider networks and working with providers. But at the end of the day, they're risk management. And so as an example, in the same way that you all are, we're very engaged directly with the patient, and they'll never see that necessarily. We'll show them video, and we'll give them anecdotal stories. The point being, what I've said to my team now for the last 3.5 years is the product here, it's the data. The data has to demonstrate health outcomes and a resulting, I hate to jump to ROI, but it's really a very pinpointed, either a improvement in revenue for some companies, that's not us, or a reduction in cost, which is us, for example. So, and that analysis, it's really clear what that analysis is. It's how many ED and inpatient stays were there for a control group in the pre-period, and for your engaged group in the pre-period, and then thereafter, in the same period thereafter, how many ED and IP visits were there, and did you reduce it or not, by how much, and what did this population cost to begin with? So with that now, if you are really, really good at this, and we're getting pretty good at this point, then you are leading the discussion about ROI that they can react to, instead of a conversation after 18 months, which sounds like this. It's like, wait a second, you're billing us what? What's the ROI here? How much have you saved? No, but wait, I see it this way. Then you're really in trouble. So the data is the product, and that includes health economics data.
I'm going to just jump in here with the bad and the ugly, because I think that I'm just going to beat around the bush here. I don't think that health plans, and I don't think philanthropy is going to fill the gap that the federal government has. I think we need to be realistic. I think that the cuts that we're going to see at the government level are going to be catastrophic and like we've never seen before. And I just don't think there's enough money in our ecosystem to do that. It's actually timely where someone like Sarita, who runs a foundation, comes in the door. I just don't think the philanthropic space and or health plans are going to be able to fill the gap of coverage that the federal government is going to leave. The second thing I'm going to say, and maybe Lauren, it's really helpful to you to speak to this for a little bit, is that I think North Carolina's experience is 1115 waiver that actually gotten through and eked out just recently. And so we're very lucky because, unless drastic policy changes, they're able to do what's in their current 1115 waiver. But I just think it's gonna be an interesting course of events where we just don't know what's gonna happen, and we're gonna have to live with what we got. And I think that the innovative companies on the stage are gonna have to be lean and scrappy. And I think you said it brilliantly, Sebastian, which is you're gonna have to show ROI, and the best thing you have is data. And I do want to speak to the pilot thing that you brought up. I think long gone are these pilots that have just been in the community and not reimbursable and not fundable. I don't think any of these companies anymore can do those pilots where their product or service or delivery system isn't paid for. And I don't think that on the other side, I just don't think that it's possible for them to be able to do that sort of work anymore. And I think that on the other side, I think the delivery system and the health plan has relied on some of that work. And in some cases, many companies have relied on that for the productizing of your MVP. I think that the solutions that are going to work the best are those that are already kind of primed for the moment, have good data, have great teams, and are able to survive the current wave that we're in. I don't know that I just figure I might as well just be honest. Laura, I don't know if you want to say anything on the policy side to back that up.
Yeah, I mean, the cuts that are proposed by Congress right now to Medicaid are just a huge, drastic shift to a cost shift to states, is essentially what it would be. If there was a reduction in the matching rate for Medicaid expansion, for example, that's 36 million people. Their coverage could be at risk if the states have to now shoulder those extra costs by the federal government stepping back and not putting as much money into those types of programs. So the magnitude is huge. It's important for us to advocate to make sure that the structure of Medicaid stays as it is, where it is that true federal and state partnership, where states don't have to shoulder that burden. There's also been recently cuts to outreach for health insurance navigator programs, for example. That's places where maybe health plans could fill in and other organizations can help fill in. So there'll be a lot of places where philanthropy and health plans can try to fill some gaps, but there's just such a huge threshold to meet if there are these magnitude of cuts as being proposed right now.
I feel like
We're
the
going to do one
data.
more last question. Oh, go ahead.
I feel like we have the data and we have the information. I mean, that's how a lot of these companies have gotten their seed money, because we've already shown that, these programs and these interventions, they work. And I think maybe the policy side can help us understand, how do we infiltrate the brains of the individuals who make the decisions. I joined a session yesterday where it was explaining, storytelling at the executive level. What is it that the decision makers or the stakeholders who are able to sort of decide on Medicaid and funding, what will allow them to understand that we need these programs and we need them to stay for the long haul?
I mean, I think the challenge right now is what was and what is.
Yeah.
We don't know what is. And so we just have to wait to know what the current what is, and then understand if storytelling is even going to work.
Yeah.
And I'm not trying to I mean, just, I think, Chloe said it earlier. I think we just have to lead with, and Sebastian, I think you guys have all said it. We have to lead with the data. I think we have to lead with the ROI. And I think private companies are going to have to lead with, having the revenue they have, and really, I hope, compassionate and really focused investors that are, hopefully they have enough runway to kind of ride through what's going to be an interesting, at least next 12 to 18 months, until we can let what's happening politically settle down. Last question.
Hi, my name is Andrew. I'm with a company called Intrepid Ascent. We do consulting for CBOs, SCNs that are involved in the 1115 waivers, as well as outside of the 1115 waivers.
Speak up just a little bit into the mic.
Sorry, is this better?
Mm-hmm.
I'm with Intrepid Ascent. We're with a consulting company that works with CBOs, SENs, community health networks that work within the 1115 waivers, mostly in California and New York now. So I'm sorry, I'm bringing a little bit out of the South. But a quick comment to what was just made, and then my quick comment is, looking at the SEN programs, a lot of them, which have already received the money, regardless of where they are in the United States, it ends typically 2027. And then there's no more money. And so the concept is to get them in a space where they can negotiate with the payers, but there's such a limited amount of time. The population health metrics and impact metrics you're going to be looking for won't necessarily be there. So we're going to have to rely on the short-term trends that we're going to see, as well as the population health metrics from places that aren't in those locations. And it's going to be a difficult conversations, because the power is going to be completely within the payer space. and the reimbursement rates may not be where they are as delineated in the program. We can be hopeful, but we're not sure. And that's kind of where our consulting role is, and part of it is to get them prepared for those conversations. But aside from that, where you're talking about the differences in CHWs, you're talking about what a CHW is in one spot isn't necessarily a CHW in another spot. And my personal experience is mostly, like I said, California and New York. Do you see the CHWs being organized in CBOs? Do you see them being organized in a hub network where there is the referral, navigation, screening services happening, or are they kind of just disparate spots? And when you do see that and you come in as startups, as technology platforms, getting them going from grants that come in from philanthropy to a billing situation, how that change management works and the challenges you're seeing in getting that change management processes through.
I'm going to just speak on one section, which is not CHW, it's doulas, but specific to New York, only because you mentioned New York and there's a new 1115 waiver that's just now kind of coming about, and only because I think it's a good use case. So the governor of New York basically mandated that all Medicaid moms could actually have access to, all Medicaid individuals should have access to a doula, right? We didn't have a doula registry. We had no access to knowing who could get a doula or what kind of doula, right? Death doula, doula for a birth, what a doula for is that, what about a stillbirth? There was no definition there. So it's been scramble, right? Every hospital system, much of them have never even had doulas within their four walls unless they're private systems, in which case it's really been mediated by the patient bringing someone in more as like a family member, even though they're paid as a doula by the private family, versus the hospitals hiring somebody. So there's all these different models right now. Individual doulas, hospital hybrid models, being hired by hospitals, right? Exactly as you're talking about. CBOs, there's not this situation where they're like, and so it's kind of this crazy crapshoot. And so this is where I see solutions like, Waymark and Pearsuite to come in to really help with tech enablement around how do we get a registry? How do people get trained? What do people do? How do community-based organizations not go out of business where they've always done this work in the community? How do we keep the structure viable, but also give people new opportunities for employment? How do community health centers that have always had this as a part of their ecosystem continue to tap in, right? But there's no one really governing this because no one really have thought about many of these questions. So I just want to use that as an example because I think it's a good, very different than the question you asked about CHWs, but it is a parallel point that speaks to exactly what you're saying. And I'll let you guys answer the question. You're really the experts there.
Yeah, I think and we do work in both states, and across the country, every CHW is in a different setting sometimes, right? Sometimes they're based in FQs. I went to a conference in Kentucky, and the CHW Association was all FQHC CHWs. Indiana is actually building a solution right now to help CHWs get jobs because they actually only work on grants and research settings. And so they only go 3 years at a time, job to job. In California, a lot of CBOs. And New York, they have, of course, the hubs. So Pearsuite was built on the different needs of different populations based on where they work, right? In Kentucky, we work with a lot of CHWs who are undocumented, right? They can't get paid through reimbursement because they have to be a documented citizen to get paid. Whereas in other states, you don't have to be a documented citizen. So how do we support with infrastructure, with the claims, with the processing, with the back end training and support to make any situation work or direct people to a situation that could help them work? For example, if an individual CHW in California wants to get reimbursed, let's help them find a hub. Let's help them find an infrastructure organization they can join, either as a subcontract entity or an employee, so they can get paid. In other states, of course, we also support hubs. So we support multiple organizations billing under one entity that maybe supports with training, infrastructure claims, billing, and NPI, credentialing. And that's kind of how we built Pearsuite. So yeah, I think startup companies have to go out there and listen and learn and ask questions and grow because this is the needs of our communities. And sometimes it's not the same everywhere you go.
Yeah, it's definitely not the same. Just working with different states with Waymark. Again, Washington State's CHW organization is different. Virginia's CHW organizations are strong. I live in New Jersey, so now I'm working to actually help build the CHW Association because we don't have one. We do have a certification process, but we don't have a CHW Association. There is a CHW hub, but there's individuals who work for health plans or CBOs or organizations like Waymark who don't even know how to congregate with their other CHWs in the area. So it definitely differs wherever you are. And I feel like right now we're all rallying together. Like, for example, with Nashua, there's a association component where the leaders of the associations in the different country come together, I would say quarterly, to understand how to help each other and again help the different states who don't have a hub or a CHW association to be able to build that workforce or just get that workforce together. So it differs in each state, and I feel like we all just work together and we give each other tips and tricks. And you call someone from Minnesota and say, "Hey, how did you get your reimbursement rates this high or yay high?" It literally differs from each place that you go, and you learn as you go.
All right. I know this has been a rallying conversation, but so much that we've lost more than half of the audience. Thank you so very much. I hope it was helpful for folks to ask questions, get questions answered, and more to come on this. More to come on investment in the South. Thank you so much.
Thanks.